Welcome to another episode of the Erectile Dysfunction Radio Podcast. Today we are joined by Dr. David Silver. Dr. Silver is the director of the Division of Urology and the chief of Urologic Oncology, Department of Surgery at Maimonides Medical Center in Brooklyn, New York. He has a private practice specializing in urologic oncology and oncologic surgery. Dr. Silver completed his residencies in surgery and urology at Maimonides and his fellowship at Memorial Sloan Kettering Cancer Center in New York. Today, we want to get an overview of urologic cancers and explore the impact on sexual function and sexual dysfunction. Before we get started, though, can you tell us a little bit about your practice?
Well, you've been off an enormous topic by talking about urologic cancers because A, they're common, and B, any part of the body can get cancer, and the netherworld or the lower part of the body is not an exception. Every man has a prostate, and eventually almost all of them will end up with prostate cancer. Penis cancer is not common in this country, but is endemic elsewhere. Testicular cancer is a relatively uncommon malignancy, but because the treatment is very well defined, studies have really been very precise about identifying what works and what doesn't. The survival is almost 100% for testicular cancer, and bladder cancer is unfortunately common because people smoke. And so it's really a fairly broad topic. To get to this, it's, 4 years of college, 4 years of medical school, 2 years of general surgery, 4 years of urology, one of which is a year of research, and then 2 years of fellowship. And so, yes, I've trained basically forever.
Okay. So around how old were you when you were done all of that and I guess actually seeing patients under a full urologic oncologist certification or accreditation?
Oh my God, mid-30s. You have to be in practice for 2 years before the board will even accept your application. And so to get board certified is an additional 2 years on top of what I just said.
Okay, so board certification comes 2 years after all of that.
That's correct. After all that training, then you got to get board certified.
Right, and that includes tests, correct? That's part of the board certification?
Yeah, the board process changes all the time, but when I was doing it, it required submission of a case log, obviously documentation of training, and then a written and an oral certifying examination.
Okay, so there's a lot that goes into this.
Yeah, it doesn't last forever either. Time unlimited board certificates are a thing of the past. We all have to recertify every 10 years.
Wow. Okay, so that exam, however it changes, is something that you have to keep up to date with.
It is. You're absolutely required to keep up to date. And the process has become a bit more involved. It used to be there was a high stakes exam and you would sit for the one exam and then that was it. You were good for the next 10 years. And now they want continuous submission of data and practice pattern and profiles and review 360 reviews from patients, from administration, from nursing, from your students, and from senior physicians. And I think it's actually good. Even though we have to pay for it every year, I really think it's actually good. It really maintains quality in as much as people are sort of required to learn what's coming up and what's next.
Coming back to your practice, I think you mentioned testicular cancer, penile cancer, bladder cancer, and prostate cancer. Are there any other cancers that are relevant to urology?
Absolutely. So moving up the urinary tract is ureteral cancer. The ureter is the tube that connects the kidneys to the bladder. Kidney cancer, of course, there are different forms. Adrenal cancer, which are cancer of the glands that are next to the kidney, are not really part of the urinary tract. They're really more part of the nervous system, but since they live in the same general area, urologists deal with them. Retroperitoneal sarcomas, which are tumors that arise from the tissue surrounding the kidneys and surrounding the abdominal organs. And sometimes some salvage surgery as well, or other adjacent malignancies like colorectal cancer or gynecologic malignancies.
Okay, so there's
a lot of ground, I told you.
Yes, it's a lot of ground. I don't know if we're going to be able to cover all of those. What are the most common urologic cancers?
Well, it would have to be prostate cancer. Every man's got a prostate, and by 70, half of men have prostate cancer on autopsy studies. By 90, almost everybody has prostate cancer. But it's actually interesting that very few people at 90 are going to die from prostate cancer. The vast majority of them are going to die from something else because they are so old and have accumulated so many other comorbidities or things that are trying to kill them first that that's usually the cause of death. It's usually not prostate cancer. In younger men, obviously, it's more of a problem because they don't have many comorbidities, have a much longer time to live. And the interesting thing about dealing with prostate cancer and studying prostate cancer is that it's the slowest growing tumor that we know of. And you can tell this because of the way the survivals are measured. Testicular cancer is measured in 2 years and 5 years. Colon cancer is measured in 5 years. Breast cancer is measured in 5 years. Prostate cancer survivals are measured in 10 and 15 years. Even if you do nothing, a lot of patients with prostate cancer are going to be alive in 10 years without any problems from the tumor.
Yeah. And that by far would be the most common. If it gets, up to, men in their 90s are almost guaranteed they're going to have some, presentation of this. But again, many of these men will not die from the prostate cancer. They will die with the prostate cancer. Something else will get them. Now,
they might not even present with it. They might not have any symptoms at all, but, and people are shocked when I tell them this. But if there's a 90-year-old guy in my office, I look at the guy, I don't need to know anything else. You probably have prostate cancer. Is it going to kill you? Very unlikely. And so the trick in treating older patients is not to find cancer, because if you look, you're almost always going to find it. The trick is to find the cancers that are aggressive and are going to be likely to become a problem within their life expectancy based on their comorbidities, family history, and so forth. And the challenge is exactly opposite in younger patients. In younger men, the challenge is to find any prostate cancer, because those guys have such a prolonged life expectancy that any tumor, almost any tumor, is likely to become a problem within their lifetimes.
Got it. Now, when it comes to testicular cancer, this is definitely something that makes many men, squirmish when they think about it. So, how common is testicular cancer?
It's really not. There are only a few hundred cases of testicular cancer in the country every year. But because it's not that common a disease, it's actually fairly well studied, because most of these in the past have been treated at major centers. And because there aren't that many of them, it's fairly straightforward to organize studies around them, very similar to rhabdomyosarcoma or Wilms tumor and some of the other malignancies. And there have been working groups that are national and international to try to define what the best treatment is. And it turns out that testicular cancer is almost curable the vast majority of the time. And that's, I'm an oncologist. I don't say cure lightly. Cure means that we get rid of the disease durably and people go on to live a long, normal life afterwards, which is important because there's a bimodal age distribution for testicular cancer. A lot of the patients are young men in their teens, 20s, and early 30s. And it sort of peaks in the late 20s and then falls off after that. And then there's a second peak in around age mid-60s.
But you're saying that this is a cancer that still is rare? It's not a common cancer?
Not that common, only a few hundred a year in this country. But it is, like I say, virtually curable. And I can't say that to a lot of people. Some of the tumors that we manage are not curable. They're manageable. Like low stage, low grade bladder cancer. Those almost always relapse. People have to go for constant follow-ups and checkups. Testicular cancer, when you beat it, it's done. The major message when I see a young man with testicular cancer, because these guys are all young. There's some of them who are just starting families, where they come in with their parents who are panicked that the kid's going to die on them. And the very first thing I tell them is that testicular cancer, you're going to live. This is a virtually curable problem. And before they leave the office, the last thing I ask them is, what's the first thing I said to you when you came in here? That's right. You're going to live.
Yeah. Okay.
If they don't remember anything else, they need to remember that part.
Well, that's the kind of thing people want to hear from their oncologist. So I definitely appreciate that. Now, you mentioned that penile cancer is not very common in this country, but it is more common in other countries. Does that have something to do with rates of circumcision?
Absolutely. It is endemic in South America, where circumcision rates are low, and it is virtually unheard of in Israel, where almost everybody, Jews and Muslims, are circumcised.
Interesting. And can you explain a little bit to our listeners what that difference maker is? How does that penile cancer develop?
It's a terrific question. Yeah. I don't know the answer to that. There's been a lot of research in that to try to figure out exactly what the oncogenic process is. And nobody's got the answer to this.
In other words, you're saying that there is a clear causality, but it's unclear what the pathophysiology is of the development of penile cancer in the uncircumcised.
That's correct. The thought process is it has something to do with retained cells that are shed by the normal skin of the penis that then degenerate and they're caught behind the prepuce, and that's called smegma. That those dead retained cells, and that somehow that becomes oncogenic. But nobody really understands the process. There's also some thought that it might be virally mediated, and there are some types of penis cancer that are virally mediated, usually by HPV. But those are actually the minority.
Okay. And what is the survival rate? Because you mentioned that, prostate is slow moving. Oftentimes there's, a lot of men do well with that. Testicular is curable, which is a, fascinating, or it's a fantastic word to hear around cancer. Mm-hmm. What about penile?
So penile cancer, it kind of depends upon what the stage is at diagnosis. And this is true for almost every cancer. With the possible exception of testicular cancer, where even high-stage disease is essentially curable. For penis cancer, if it's confined to the penis and appropriately treated early, then the survival is excellent. Once there's lymph node spread, those numbers go down by half. And when it's disseminated, there's no good chemotherapy and there are no survivors. The problem with penis cancer diagnosis is that men just tend to ignore it. I got this thing on my penis. How long you had that? Oh, about 8 years. Really? Did you come to see a doctor? Nah, I didn't think it was anything. People really do tend to ignore it. And it's less so for testicular cancer because it's interesting. But a lot of times testicular cancer is found by the partner, right? Because, there's a little foreplay going on and the partner says, oh, what's this? And the guy's like, nah, isn't it great? It's bigger than it used to be. And it's completely misinterpreted. But with penis cancer, there's a real... sort of a stigma attached to it.
Yeah. And to that end, is this something which is externally detectable?
Many times, yes. Sometimes if there's a really bad phimosis, which is a contracture of the skin at the tip of the penis so that the skin can't be pulled back to see the actual head of the penis or the glands, sometimes it's hidden and it's occult and somebody wouldn't see it. But the vast majority of the time, it's at least in my experience, it's been relatively obvious.
Dr. Silva, the last cancer that you mentioned that I want to explore a little bit more about, because I think this could have a direct impact on sexual function, is the urethra or urethral cancer. Can you describe a little bit about that? I mean, from what I know about my own body, the urethra is not a very wide port. Now, I know that it may extend back into the body, but it's a pretty narrow band, correct?
So the urethra drains the bladder and comes all the way out to the penis. And when it's generated by folding up a couple of different areas of tissue in the embryo to make the urethra. It's not all made out of the same stuff. And so the proximal part of it, the first part of it that's right up near the bladder, is actually generated by tissue near the bladder. And the lining of that is very similar to the cells of the bladder. And the distal part, the part all the way at the end, is generated from the same type of tissue that made up the penis and the skin of the penis. And so those cells are completely different. This is a rare tumor to begin with, and there are multiple subtypes based on the location. And again, this is one of the things where the stage of presentation makes an enormous difference. It's very hard to pick up when it's early. And when it's late, it used to be considered absolutely incurable. Now with combination treatment, including chemotherapy, radiation, and surgery, some urethral cancers are curable.
And you mentioned that the cells are they're very similar to or are actual bladder cells or penile cells. Does that mean that men who develop bladder cancer are at higher risk for developing urethral cancer in that region of the urethra, or men who have developed penile cancer, are they at higher risk for developing urethral cancer as well in the area closer to, the tip of the penis?
That is a terrific and somewhat nuanced question. So for people with distal urethral tumors, the ones that are more similar to the outside of the penis, the answer is no. Once you remove that, there isn't any increased risk to the rest of the penis. For people who have had bladder cancer, the rate of urethral cancer is actually not insignificant. And it's sort of an interesting biology because let's say somebody has their bladder taken out for bladder cancer, which should solve the problem, right? If you leave the urethral stump closed off, then the risk of having a urethral cancer in that stump related to the bladder cancer is actually higher than if you were to build a new bladder inside or a neobladder and connect that to the urethra and have urine flowing through it. Doesn't make any sense, right? But biologically, it's true.
Yeah. So it sounds like maybe at some day there will be an explanation.
I don't have a good explanation for this. I mean, we used to think that it was an issue of detection, because when there was a urethral stump, you wouldn't do any of the urethral wash cytologies, and we didn't know, and so the rate of detection would be higher. But it turns out that even if you do surveillance of the urethral remnant, the rate is still low, higher in the stump than it is if you've got a neobladder connected.
It's very interesting. Okay, so I'm sure there's no end to what we could talk about just around the cancer. But we do want to kind of bring this back towards sexual dysfunction. So as I'm thinking about, again, penile cancer, urethral cancer, testicular cancer, these are all regions that are, part and parcel of sexual function. Mm-hmm. Do any of these cancers themselves, not the treatments, but the cancers themselves, interfere with sexual function?
So the answer to that question is sometimes. Urethral cancer itself, there's not a lot of data on whether it interferes with sexual function or not. It's usually in older people. It's a rare tumor, and so I'm not really going to be able to make much comment about that. I can tell you that some of the penis cancers do interfere with sexual function because they're large, frankly. And they can cause problems with the erections, depending upon the location. Prostate cancer, in and of itself, generally does not cause problems with sexual function. So sexual symptoms, apart from perhaps blood in the ejaculate, aren't really a symptom of prostate cancer. Bladder cancer rarely causes sexual symptoms, but the treatments can have of all these diseases can have profound effects on sexual function. Testicular cancer doesn't really affect sexual function most of the time, but it does affect fertility in a large way.
In other words, the mechanics of sex will work with Correct. Testicular cancer, but there may be impact on, I guess, sperm production. Is that?
Yes. It turns out, interestingly, that although most of the time a single testis is affected, to have both testicles affected by cancer simultaneously is vanishingly rare. I've actually never seen it. But the opposite testis is somehow affected to some degree. So about 40% of patients who have a unilateral or one-sided testicular cancer actually have a decrease in semen quality compared to otherwise normal men. And that's also another thing that's not well understood. There's clearly some hormonal or other non-contiguous influence, but that hasn't really been well worked out yet either.
For many people, when they hear of a cancer diagnosis or they suspect that they have cancer, there could be some very profound psychological impacts leading to sexual dysfunction. In your practice, is that something that you see or that you hear men reporting?
It's hugely common. There's immense anxiety associated with the diagnosis of cancer, any kind of cancer. Even patients who are not yet diagnosed with cancer, people with elevated PSAs, prostate-specific antigen tests that may indicate they have an enlarged prostate or prostate cancer or prostatitis. Even those men come in complaining that, it used to work really well, but now for the past couple of weeks since I got my PSA, I think things are terrible. And it's a urologic joke. The PSA is not prostate-specific antigen. It also stands for patient-specific anxiety because people are just so nervous about their PSAs. And it's a common thing. People get a slightly elevated PSA and they go to meet their buddies at the pool and the guy says, "Hey, what's your PSA?" "My PSA is 5. "Oh, my PSA is 3. You got to see my urologist." And there's this huge, we've done a really good job pushing PSAs on people and PSA screening to the point that even just an elevated PSA makes people very anxious. But any diagnosis of cancer is tremendously anxiety provoking. Some of the treatments, as you know, cause a lot of anxiety associated with them and can cause physical dysfunction. To me, the most interesting group of patients in this regard are patients with low volume, low stage prostate cancer, whom we no longer really treat. My professional society says that for low risk or favorable risk prostate cancer, you're not even supposed to treat it because we know that it doesn't kill people. Mm-hmm. But and surveillance is supposed to be the first line treatment, for most of these patients, because we know it's not going to kill them. But the number of patients on surveillance who will fall off of surveillance because of anxiety about, oh my God, I got the big C and I'm not doing anything about it, I'm going to die, is tremendous. Only about 4% of those patients per year require treatment because they either have progression in grade or progression in tumor volume. But almost 30 to 50% of patients across the board on surveillance for prostate cancer will fall off at some point because they're just anxious. And a lot of that plays into the rest of their lives as well. And that includes sexual dysfunctions. It's very, very interesting.
Yeah. And it will be interesting to look at, and I don't know if this has been studied, but as we're talking here, I kind of wonder if, because again, cancer forms all over the body and it has a psychological impact for many people. Wonder if there's a discrepancy between urologic cancers, which are directly associated with or correlated with the sexual function process, as opposed to cancer in other regions of the body. I don't know if anybody has done that research. Certainly something that I, after this conversation, will be looking into a little bit further, if that has a specific psychological impact on sexual function that is at a higher rate as compared to cancers in other regions of the body. Now, are there ways to mitigate the impact of negative sexual function outcomes when it comes to treating some of these cancers?
So for each cancer, it's a little bit different. And again, it's a little bit nuanced according to the patient and according to their pre-existing functional status, which almost all men overestimate. And so, a patient, my professional society says that you're supposed to ask patients with prostate cancer. I'll use prostate cancer as an example because there are really a lot of guidelines associated with it. And so in the initial history, you're supposed to ask patients about their urinary symptoms. That's one of the things that it can affect, and ask patients about their sexual function. And so patients come in with their partners, right? And so, I asked this question, I asked you this, but, I got to know something about your sexual function because, a lot of the treatments have sexual side effects. And the guy will look at me and then look at her and say, and not say anything. And so I almost always turn to her or turn to him if that's the partner and say, well, what do you think? How is he compared to how he was, 20 years ago when y'all first met? and it's a light moment in the office visit, but it does establish a baseline for a very serious topic. Because people are, it's always at the very end of the conversation when at a doctor's visit where a guy throws out, oh yeah, by the way, can I get some of those pills? And this brings it right out to the front and makes sure that people are upfront about it. And it helps to set the expectation for what's going to happen later on. And so for men who have good sexual function to begin with, if a man is about 65, I can tell you that half of those guys, according to the literature, are going to have trouble after a prostatectomy. 40% of them are going to have trouble after radiation. 20% of them are going to have trouble after a focal treatment, like ablation with either high-intensity focused ultrasound or cryoablation. And some of them will still have trouble even if they go on to surveillance.
Yeah.
And so it's really important to have a baseline with these patients.
Yeah. So that's for prostate cancer. Now, mm-hmm. I know we haven't gotten into the specifics of the variations of treatment, or if there is any variation when it comes to penile cancers or testicular cancer or whatnot. Would there be any associated sexual dysfunction with those treatments? We've covered in a previous podcast the specifics around a prostatectomy and how delicate the nerves that kind of line right around or run right against the prostate are and how long it takes for them to repair. Now, I don't know where else those nerves go. Maybe you can enlighten our listeners as to what the impact is of other cancer treatments.
So let's go back to your two examples, testicular cancer and penis cancer. For testicular cancer, one of the things that's important to sexual function is to have an appropriate hormonal milieu. adequate testosterone, which helps with desire, and that also affects function. There's actually enough testosterone produced by a single testicle to give normal levels of desire and a normal level of sexual function. And so testicular cancer, if it affects one testicle, as it almost always does, is usually in and of itself not an issue with sexual function. Penis cancer, on the other hand, because the treatment of the primary tumor necessarily involves removing that portion of the penis that's got the tumor on it, that has profound implications on sexual function. And so, the industry standard used to be, and all the old textbooks say this, that no matter where the penis cancer is, whether it's on the shaft or whether it's on the tip of the penis, if you remove it with a 2 centimeter margin from the tumor back, then that has basically 100% effectiveness in solving the problem where it started. The problem with this, of course, is that everyone's built a little bit differently, and to a distal amputation or removing just the tip of the penis on one guy with a 2 centimeter margin is going to leave him with enough of a stump to stand to urinate, but you won't be able to really penetrate. Whereas in other more, shall we say, endowed men, that same amount of tissue removal is going to leave him with almost no sexual side effects. Now that's just in terms of being able to penetrate. Remember that the glans or the tip of the penis, of course, is full of nerve endings. And, that's part of arousal. And arousal is sometimes more difficult in men who have had some portion of the penis amputated. And so for lower grade, very distal disease, now the treatment has turned completely away from amputation and more towards organ conservation or sparing as much of the tissue of the penis as possible. And so there is something called Mohs surgery, which is called micrographic surgery, where the resection of the tumor is done incrementally. A portion is removed, the piece is mapped, sent for pathology immediately. Any place where there is additional tumor that needs to be removed, just that location is removed, mapped, and the process is repeated until there is no tumor left. And that preserves layer by layer as much tissue as possible.
Yeah. So to that end, I was wondering, does a penile tumor or a penis tumor, does it grow into the corpus cavernosa?
Absolutely. Most of these start on the surface of the penis. So they're squamous cell carcinomas, and they start on the surface of the penis. Even the verrucous ones that come from HPV start on the surface of the penis and burrow their way in. And the risk of lymph node metastasis and distant spread is directly related to the degree of invasion.
Got it. So the sexual dysfunction theoretically would also be dependent on how deep into the corpus cavernosa this is penetrated?
So in my experience, generally not. I don't think that depth has been, I don't think that study's actually been done. But in general, even people who have corpus cavernosa involvement report the same degree of sexual dysfunction.
Same degree. So you think that doesn't have any impact?
They still have erections.
Yeah. And how, so the blood just do the vessels grow around the part that's been impacted or removed, or how does that work?
No, the tumor grows in from the skin through the tunica albuginea, which is the fibrous sheath surrounding the corpora, and then into the corpora. And as long as there isn't really an associated leak of blood through the tumor and into the veins draining the penis, then there's no loss of the ability to have a normal erection.
How does sexual counseling for these cancers and cancer treatments, how does that look, or how does that take place in the broader context of patient education and informing patients about treatments and the potential impact?
So we have a cancer center, and there is a sexual counselor associated with it. We have every level of counseling, and sexual is part of it. I got to tell you, most people in the very beginning are less concerned about function than they are about life expectancy. And this is a consistent theme when presented with a new diagnosis of cancer. All I want to know is, am I going to live to get married? Am I going to see my grandchildren? And the sexual stuff. Don't worry about that. But it's fairly important for patients not to rush into any treatment until they understand the potential side effects and alternatives that may provide better or different sexual and other outcomes. I mean, again, this is relevant to prostate cancer, but it's also relevant to other treatments as well, to other diseases as well. For example, with bladder cancer, bladder preservation, as opposed to removing the bladder for muscle-invasive bladder cancer, is associated with far better sexual function than removing the bladder. And while the knee-jerk reaction for many patients is, oh my God, just get this bladder out of me, I don't care what happens to me afterwards, in the long run, it might not necessarily be the right answer. And so it's really critically important for patients to bring somebody with them to the appointment who can listen a little more carefully and doesn't have alarm bells ringing in their head every time you say something to them.
We as human beings are wired with a hierarchy of needs. And it is somewhat of a parallel to how we talk about, psychogenic erectile dysfunction, which is if you are anxious, that's your body's, your body goes into a mode of trying to protect itself and preserve, and blood flows, to your primary organs, your penis not being one of them. And that is also the way we think, which is survival, above everything else. So when we hear cancer, it's do anything and everything you can to get that cancer as far away as possible. Even if you resect half of my body, just get it out. And it's important for people to kind of slow down and recognize that there's a broader picture of quality of life post these treatments that certainly should be taken into consideration.
So here's what I tell patients. I tell them that, what's your goal? The goal in cancer treatment is death of other causes. It may not be necessary to kill every cancer cell to achieve that goal. And so this, 60-year-old idea that extirpation is the goal might not necessarily be true for you. And when you think about it in those terms, it sort of gets people to realize, well, I am going to have a life after this, and I kind of like to look forward to what that life might be like. And I tell people all the time, decisional regret is an enormous factor in there's a huge literature on this in prostate and in other cancers. And, the last thing I want is a guy sitting across the desk from me 10 years from now saying, oh man, I should have done the other thing. So it's never good for somebody to rush into any treatment. Yeah. The good part about this is that for most cancers, it's not an emergency. And it bothers me when people come and they say, oh, my doctor said I have to do this immediately. Well, no, sit down, think about this, decide what your goals are, go home, talk to your family, come back, write down your questions. I'm happy to talk to you about this. If sexual function is a big deal, let's talk about it. This is something important to you. This is a relevant value to your care.
Yeah. And I mean, it's, that patient angst and anxiety about just get it out of me, do whatever you can. I think it's very common. I can definitely understand, how that is a big driving factor for many people. But at the same time, taking just a couple days, like you said, there, to my knowledge, things don't progress that aggressively over a couple of days or even weeks, generally speaking. Certainly, if your oncologist has seen the scans and sees what's going on, when they say you can take a couple days or weeks to kind of think this through or figure out which, treatment approach is most appropriate for you, they mean it. It's really okay to take that time and think through all the implications.
I think that's absolutely true. Everybody wants to know, am I going to die? And the answer is, yeah, we're all going to die, but not tomorrow. Next week doesn't look good either.
Can appreciate that. Well, Dr. Silver, this has been so informative, both for myself. I'm sure our listeners are going to benefit from hearing about this. I know there's a lot of emphasis on prostate cancer, and for good reason, because it seems to be the most common cancer in the urology family. And I think what was shared with me is that it's the second most common cancer for men, after lung. If I think that was maybe what was
lung.
After lung. But just hearing about these other cancers, be aware that it's highly unlikely, they are rare, and there are many good treatments out there. Certainly if men suspect that something is going on, like within reason, go to your doctor, get it checked out, and get ahead of it earlier rather than later. And this really should not have broad, long-lasting effects on sexual function. Most of that is probably driven by the anxiety of the cancer diagnosis much more than it is of the cancer or of the long-term effects of the treatment. Is that an accurate summary?
I think that's relatively accurate. People are afraid. They're afraid of what they don't know. Am I going to die? What's going to happen to me? And they're also afraid of what they heard what cancer was like 40 years ago. There's a lot of cultural baggage that people bring with them when they talk about cancer. And so the real message that people should take home about cancer is that this is not 40 years ago, right? Many of these tumors are survivable with a good quality of life and a normal life expectancy. So don't be afraid. Come on in. Let's talk about it.
Okay, and I appreciate that. It's relieving for me to hear. I hope it's relieving to our listeners as well. And again, thank you very much for your time. We really appreciate that and can't wait to get this episode out.
My pleasure. Thanks for having me.